Hey, good morning, everyone. Welcome to Euronurse. I'm your host, Frank Senese. We meet every Saturday at 9 a.m. Central Time. And if you're watching us on YouTube, Facebook, or LinkedIn, welcome to the show. Hey, do me a favor, all you YouTubers out there, hit that subscribe button. We're trying to build up that subscription base. If this is your first time joining us, be sure to check out our show on euronurse.com. Euronurse.com has all the information about the show that you're going to want to know about. It's also the best place to go to check out our episodes, and we've got 47 past episodes. Also, if you're going to be joining us live and you want to send in a question, be sure to use that comment box right there on the bottom. Fill it out, and you can send your question to us no matter how you're watching us. The comments box is live for all avenues. We got a really great show for you this week. My youngest brother's joining us, Frank Senese, who's RN, and he's in hospice. And I thought that'd be interesting to hear their take on some of the urology stuff they do and what hospice is all about. So we're going to bring in our experts right now, and let's meet our experts. Hey, welcome, everyone.
Good morning.
Morning.
So I'd like to just have everybody do a little introduction, but if you have a favorite story after you introduce yourself, we'll have you go ahead and share that favorite story. I'm going to kick things off since I'm on the big screen with my favorite story. Everybody knows I just told you I'm the host. I've got about 40 years of urology, 40 years of nursing experience, most of those spent in urology. So I thought I'd go back and tell you about the good old days, which I kind of refer to as the golden days of medicine. And I've been involved in this long enough that I was here well before the pharma guidelines were in effect. And for those of you that don't know what those are, that's when pharmacies could do whatever they wanted to promote their drugs. And they did. And I was lucky enough to be able to enjoy a lot of that, being the nurse working with the group. They would invite me along to these things. So they would, have drug dinners for introducing new medications. But back in those days, you could bring your spouse. So my wife got to go on many a nice dinners with me. And they would also do other things besides that. I was at Wrigley Fields to watch the baseball game they bought up an entire upper deck from one of the buildings across these fields. For those that aren't familiar with Wrigley, they've got these buildings that have their own stands set up. So I got that. Disney Quest was new, and they brought Disney Quest to Chicago, and they bought out Disney Quest for a night and got to bring all the kids. So they thought that was great. But the best one, the topper, was I went to a basketball game during March Madness at the United Center, which is the home of the Chicago Bulls. And they had the skybox rented out. And they said, you got anybody that really likes basketball? I said, yeah, I do. I said, my son is really into basketball, and he was in high school. So I brought him to the game to see the game from the skybox, and he was thrilled because he never had that kind of treatment from me. I didn't kick in the money for a skybox. And then they come in with the cart with all this food. And he's like, Dad, do we get to eat this? I go, absolutely, anything you want. So those were the golden days. So that's my favorite story. All right. Let's kick in and bring John in here. Were you around before pharma guidelines or no?
Just before. And yes, the box seats and the concerts and the dinners where you get to bring your spouse, golf outings, but no strip clubs, no fancy trips no fancy trips to exotic places, Hawaii, Tahiti. No, none of that. No golf clubs, maybe golf balls, but no golf clubs, no free golf clubs or anything like that.
Yeah, they were getting a little more conservative.
It's self-imposed. Pharma guidelines are created by themselves. So it's self-imposed. And what you can do, they used to give out pens and pads thinking that they stopped doing that because they thought that would influence prescribers' behavior. Yeah. Well, if they can't do that now, you as the prescriber, you as the practice now can give those things away. So take advantage of that.
Yeah, we do. We have our pens with our office name on it. So you're right. Any favorite story for us, John?
Oh, they're always favorite stories. I just want to say that I'm a private practice urologist in Gilbert, Arizona. And like Vic, I am paying it forward by sharing my experience in the business of medicine to benefit my colleague. You see, I've been extremely blessed coming here as an immigrant, starting from nothing, and to be able to live now beyond the American dream. One of the ways that I'm doing so is by creating the Thriving Urology Practice Facebook group, where we have over 2,300 US based urology practice folks collaborate to improve our practices. And we just reached our 5-year mark yesterday. And it
Hey,
is
congratulations.
yeah, thank you. And it is all for free. And I like to say, if it's free, I'll take 3. Have time for a favorite story?
Yeah.
Very quick and brief one. Saw a guy who was in the practice for low urinary tract symptoms, BPH, came in as a new patient. And I always like to find out, well, how did you find us? And he said, I actually went to another urologist, just one city over, one town over. And the urologist said, go see Dr. Lin. And I said, well, he's literally one city over. Why are you here? And the reason why he was here was because the other urologist did not offer telemedicine services. Initially, when I see patients, the new patients, I like to see them in person, do the examination, check out any urinalysis, order any labs, etc. That initial visit, that new patient visit, is usually, almost always, an in-person, face-to-face visit. Subsequent visits, if they're from far away or if they're really smart, when they realize that we're just going over results and changing plans, it does not require a physical examination or blood test. You can, and it is an established practice to perform this under telemedicine, meaning a face-to-face virtual communication, virtual interaction. This other urologist did not offer that. And that's why this 77-year-old guy with BPH came to see me, because we offer telemedicine. So why am I telling you this? You want to try to meet your patients where they are, understanding their life circumstances. If they have financial issues, try to work around them. And in coding and billing in 2020, since 2021, 2 years ago, social determinants of health comes into play in the risk section of your evaluation and management medical decision-making area. And that social determinant of health allows you to bill that section only, not the entire encounter, that section only. That's a level 4 or moderate risk. So meeting where your parents are, offering telemedicine, is good for the patient and good for you as the practice. Back to you, Vic.
Yeah, good point. All right, let's bring Lori in. Lori, tell us about yourself and favorite story if you got one.
Hi, my name is Lori Atkinson. Welcome all. I'm a certified urology registered nurse. I've been doing urology for 25 years now, and I currently work for Northwestern Medicine at Delnor and at Central DuPage Hospital in Illinois. So I have something that kind of, I guess, relates to hospice. This was many years ago where I had a patient that didn't quite qualify for hospice. They didn't even quite qualify for home health. I had been changing a suprapubic tube for years, and it often clogged. And so they're probably in their 80s. She calls me on a Friday afternoon. Of course, we're all ready to leave. And she's like, Lori, his catheter's clogged, and I really don't want to have to take him to the ER and so forth. And so she happened to live the town over from me. Now, I'm not recommending for anybody to do this, but I did bring my supplies. I went to her house and I did help her out and change that catheter for her so that she didn't have to go to the ER. Again, I'm sure it probably was illegal. I shouldn't have probably done it, but she was very thankful. And that's just, that's the type of nurse I am. I don't want them to have to go to the ER and wait 4 hours to get a catheter changed or irrigated or what have you. One of my goals, and I've been thinking this for a very long time now, there's a lot of patients that really have a hard time getting into the office to get, their catheters changed, and to do it monthly or even sometimes less is so hard for them. And unfortunately, a lot of times they don't qualify for home health just to change catheters or take care of catheters. And that's something I'd like to pursue in the future. You know, why can't patients have just a nurse to come out and change their catheters? So I don't know where that is at all right now. I mean, this is a long time ago. I was thinking about it, and I know there's probably a lot of legality towards it, but anyway, that's what I've got.
No, like John said, there's an unneed met being out there. I agree. You know, some of these patients would be good candidates to have a visiting type service come out to change catheters instead of having to come into the office.
Those
All right,
home health nurses are available though.
Home health, yeah, but
some people don't
there are
qualify.
some restrictions. I remember, like, if they're going like get to a barber shop or something to get their hair cut, they don't qualify for home health. So there are some restrictions. All right, we're going to bring in our guest speaker now, Frank Senese. Tell us a little bit about yourself, and if you got a favorite story, then we'll get to your show.
Hi, I'm Frank Senese. I've been a nurse since 1991 is when I graduated from UIC. I currently work in hospice. I've been doing hospice care nursing for the past 3 years at Advocate Hospice, Advocate Aurora. I work the support care team, which means that I don't have a set group of patients like a lot of the clinical nurses do for hospice, where they have the same patients that they go and see. I work the 7 p.m. to 7 a.m. shift, usually every Tuesday and Friday, because that works best with my schedule with my other job. And during that time, I get out and I see patients who usually have acute needs that come up during the night. It could be that they've died. It could be, and I have to go do a death call, or it could be that I have to do a Foley insertion, which I've gotten a ton of calls for Foley insertions. Always have, at least 3 to 6 Foleys in my trunk ready to go, because you never know when you're going to need it. And the last thing you want to do is show up to the house and find out you don't have a Foley in the back of your car. So I usually start my shift by making sure my supplies are there. My other job, since I've already mentioned it, is I also run the fingerprint system for the state of Illinois. I know that has nothing to do with nursing. So those of you who got your degree in nursing and think that that's all you can do, there are other options too, just because you have the degree. I have a 28-year career now with the Illinois State Police. So it has nothing to do with nursing. Favorite story? I was thinking about this. You have lots of stories because you have lots of patients that you don't see. It's more like ER nursing, where you don't usually see your patients more than a couple times just because of the trajectory of their health on hospice. But I do remember going in for a patient who had esophageal cancer and a clogged G-tube. And I think that it was just a matter of, I had to do teaching on making sure the G-tube was properly flushed afterwards. But I get there and they had never heard of using Coca-Cola to try and bust through the clog. And so I get there, I'm like, well, do you have a Coca-Cola? And she goes, oh, are you thirsty? And, no, I don't drink pop. I need it to bust the clog. And she's like, really? You're going to use Coca-Cola? And I'm like, oh yeah, it dissolves pretty much anything. And we got into a discussion about how it takes the rust off of bumpers and
teeth.
Yeah, and the denting off your teeth.
Yeah.
So we start, I got my Coca-Cola and I'm hitting there with my 60cc syringe, pumping it back and forth. All of a sudden, I have perfect flow. And she's like, oh, this is fantastic. I'm so glad. We were so worried he was going to have to go in and have another tube put in. I'm like, no. Let's explore everything before we get to that point. So that's my story for today.
That's a great story. So yeah, the Coke in, they hit a smile later.
Yes.
All right, Frank, we're going to bring in your show and let you take it away right now.
Okay. Today's kind of going to be an introduction to hospice, because a lot of people don't understand what hospice actually is, unfortunately. And we'll talk about why that's important. So, I always hate when everyone starts off with a definition. What's the definition? But because hospice is so misunderstood, I thought I would begin. Hospice essentially means host or guest. Started back in the 4th century. Actually, 1065 was the first hospices in the Malta area. In the 4th century, we had the monasteries that were providing support to the religious orders, as well as pilgrims and the elderly and seriously ill. And the whole idea behind it was to giving charity to the poor, feeding the hungry, giving a place for travelers to rest, and taking care of the dying and healing the sick. What hospice is and how it's a little different than your regular care is it is patient and family centered. It's specialized care for people with serious illnesses. The difference between palliative and hospice being palliative is, comfort care for patients at any stage, where hospice really focuses towards the end of life. It tries to optimize the quality of life and prevent suffering for the patients. To be able to get onto palliative care, you must have a progressive disease that requires pain or symptom management. For hospice, you have to have a diagnosis of an expectation of 6 months or less of life. As far as some of the symptoms or some of the conditions that we normally see, heart failure, COPD, a lot of cancer, end-stage renal disease, liver disease, neurological diseases, dementia, all types, and cognitive impairments. So most Americans in the healthcare system, they think that when they get sick, well, the hospital's going to take care of me. Well, in a post-COVID world, most times when you're trying to get an appointment, it may be difficult. In fact, I was talking with one of my employees yesterday at the state police who said that the earliest she could get in for an appointment for not being able to hear out of one of her ears was August. So the appointments have really, really jumped since COVID. Sometimes doctors' recommendations are confusing and difficult to follow for even those of us who speak medicine and speak, medical terminology. Sometimes it can be confusing. We have to ask for clarification. And most important is the costs that can be unexpected and devastating. 40 million adults in the United States have experienced serious illness in the past 3 years. We have more than 41 that have unpaid care for elderly adults in the past year. And the stress that goes beyond just the specific disease of what may be bringing someone into the hospice environment. 62% of people feel anxious or helpless or confused over their diagnosis. 48% say they have emotional or psychological problems caused by their condition. And 32% report that they feel left out, that they're lacking in companionship, that they're feeling isolated from others. It's a profound loss. It's a loss of control, a loss of independence, a loss of time, a loss of capabilities. I remember having many discussions with my mother when she was in hospice about the loss of what she had and the loss of truly her independence, which was the hardest for her because she was such a strong, independent person, and having to let people take care of her was horrible for her. But we talked about it from a religious perspective, and we talked about how it was helping other people to gain what they may need for their religious beliefs and being able to take care of another person. And that gave her some relief as well. But a big fear of people is being a burden physically and financially to their loved ones. The physical, emotional, financial toll, it's life altering for these people. It can be an end of all the activities that gave life pleasure. It can be growing isolation from friends and family. People don't know how to support you. One of the hardest things with people when they have a terminal illness or a serious illness is other people not being able to understand what they're going through. Because if you haven't experienced it, you have no clue how to react to that and what all that loss actually means. I know I'm hitting with a lot of statistics, but some of them can be a little staggering. 53% of survey respondents who experienced one or more dire financial consequences related to their care, such as using up most or all of their savings, being unable to pay for things like food or heat or housing, or having to borrow money to get a loan or another mortgage. When 9 out of the 10 had insurance that would cover their serious illness for their final days. Healthcare is expensive. The caregivers also report that they're scared, they're stressed, they're isolated, they're exhausted. They keep on pushing themselves to go further and say, well, I can rest later. They're staggering, trying to do things that they've never done before, like toileting and feeding and bathing someone and taking care of medications. It's frightening for these caregivers. And what we can hospice try and do is bring them the support that they need to be more comfortable. So a lot of hospice is teaching, just like a lot of nursing. So some of the big questions is, who pays for hospice? Vic was mentioning before we started the show, having a neighbor who was concerned about losing his house because of going on hospice. And people don't understand that Medicare Part A, there's a hospice benefit under Medicare that covers 100% of the services related to the hospice diagnosis. And the hospice services are not subject to a Medicare deductible. Medicaid follows Medicare, and even most private insurances have a palliative care coverage. And hospitals embed palliative care into the hospitals and clinics costs due to the benefit that these services provide for the seriously ill. So for hospice, how hospice gets paid is there's a per diem daily rate that varies based on the level of care and the county which the patient's receiving services. It covers all services needed to manage the terminal condition, which includes all the core team members, all the medications, the DME or the equipment, medical supplies, home health aides, the physical therapy, the occupational therapy, speech therapy, bereavement volunteers, and the pharmacists. So anything that's related to the hospice diagnosis, and even some of the things that are not related to the hospice diagnosis, are all covered under Medicare Part A or Part D when we're talking medications. What's not covered is live-in housekeepers or personal care items, nursing homes and inpatient hospice rooms and board charges, inpatient and emergency services without prior approval of the hospice team, or transportation. With Advocate, it's a home-based palliative program, a nurse-led model supported by an interdisciplinary team. The patients must have a primary care physician with an advocate physician partner. They must live within the geographic service area, and either the nurse practitioner or the doctor or DO will bill the insurance directly for their visits. It's provided under traditional Medicare, Medicare Advantage, or Blue Cross Blue Shield attributed. So our interdisciplinary team, the main core is your board certified physician who's going to do the consults and oversight and may be supported by a nurse practitioner. You have your nursing staff who's going to provide the service for symptom management and advanced care planning. We have the social work services that are going to provide psychosocial concerns, resources. They'll help set up nursing homes for respite stays, as well as some of the other functions that people need help with. Then we have our chaplain services for spiritual support. So you can see it's really a team approach to taking care of our patients. What makes people hospice eligible is they obviously, again, have to have a terminal illness. And there is a certificate of terminal illness filled out by the physician. It's usually filled out by the person's attending physician and backed up by one of our hospice physicians. It's completed by the attending, and it's completed at the admission process. I like this little cartoon because it's kind of the myth of hospice. Is hospice is for patients who are very close to death, and we have death sitting one seat away from the patient, and the nurse saying, "I don't think you qualify because death isn't right at your bedside." That's not what hospice is. We're not waiting for people who are just on the verge of death. An ideal world, hospice would be able to be given to people for months. When we look at the types of diagnosis that we see in hospice, more than half of them are cancer. And the trajectory of cancer from diagnosis to people going on to hospice, it can be a long period. And just because you go on hospice does not mean that the curative process has to stop. It can be run in conjunction with. So you can still be getting your cancer therapy treatment and still be on hospice as well. It doesn't end that therapy. We have different levels of hospice care. Routine is the most common, general inpatient, respite, and continuous. And I'll go through each one of those. Each level of care is supported through the patient need and documentation. If we have someone who's general inpatient, for example, where they're in the hospital for treatment, every time we're charting, which is on a daily basis, we're charting why that patient needs to stay on general inpatient care. Once the patient can be discharged back to the home and back to routine care, then discharges are done. But we don't need a new certificate of terminal illness for any change in the level of care. So routine, again, is the most common. It occurs most frequently in the patient's home or in a residence if they're in a nursing home. And the patient is usually being cared for by a family member or a formal caregiver, but the expenses for that are not covered by the hospice benefit. So caregivers in the house are not reimbursed through hospice. That's at the patient's expense. For general inpatient level of care, it's usually for pain and symptom management at crisis levels that they can no longer be managed at the home. It's usually short-term and medically necessary, and the care must occur in a hospital or inpatient hospice setting. An imminent death is not enough of a reason for someone to be put on GIP, or general inpatient care. So again, most of our treatments are for pain management or symptom management. It could be shortness of breath or pain or another condition of the patient that is not being able to be handled in the home. And when we have someone on general inpatient, we collaborate with the hospital staff to provide the care for the patient. The care remains under the supervision of the hospice team, but we allow the attending physician in the hospital to run the care directly in the hospital. Our interdisciplinary group of the 4 key components, the doctor, the case manager, nurse, the social worker, and the chaplain, all will review the inpatient records to ensure that everything is in agreement with the plan of care for the hospice team. We start discharge planning the minute someone goes on to general inpatient level of care. So the very first day when patient is being admitted into general inpatient, they're also having some form of comment on the discharge planning. It may be that discharge planning is not possible at this point, but we're mentioning some form of what is the discharge idea if we are able to discharge this patient. And the idea is that once the symptoms are controlled, the patient's level of care will go back to routine. Respite care is, to me, one of the best things that we have on hospice. It's a short-term inpatient care to give the patient's family or caregivers a chance to get a break. It prevents the caregivers from getting burnout. It can go for as much as 5 nights in a contracted facility. And then after the 5 nights, the patient comes back home on general routine, and it may be as short as a day, and then they can go back on respite level of care. So you could have back-to-back respite care throughout your entire time on hospice, where the caregiver may not be taking care of the person 7 days a week. They may only be taking care of the person 1 day a week because we have back-to-back respite level. You can have, again, multiple respite levels, respite stays within the benefit period. And the hospice team continues with the same plan of care, potentially adjusting the plan of care based on our patient need. And the visit frequencies, again, will stay the same as the routine level. Continuous level of care is probably our rarest form, and that's for brief periods of crisis symptom management or caregiver breakdown, where we have to have a nurse coming out and providing care for the patient on a 24-hour basis. Now, the nurse doesn't have to provide care for the entire 24 hours, but it must be provided for 8 out of the 24 hours. After that time period, the remaining hours can be picked up by a home health aide or other hospice members. However, at least 8 hours of that 24-hour period has to be covered by an RN or LPN. So what makes hospice nurse different than other types of nursing? Again, our focus is on care and comfort, not cure. Our focus is on the family and the patient. Our care is provided wherever the patient calls home, whether it be a nursing home, their private residence, a skilled nursing facility, a hospice resident, or even a hospital. The hospice Medicare benefit, established in 1983, is the largest payer source for all of the hospice and makes up over 85% of all the paying for hospice. If we look at how Americans dying in the past 3 years, the majority of people have died from heart disease, number 2 being cancer, and number 3 being COVID, and then goes down from there. So the majority of our patient population has a diagnosis of heart disease or cancer. These statistics are one of the ones that really strike home with our hospice staff, that 80% of Americans indicate that they want to die at home, but only 20% of them actually do die at home. That's a huge, staggering statistic, that the majority of Americans who want to have the comfort of being able to die within their own home aren't actually dying in their home. And 60% of the Americans are actually dying in acute care hospitals, and 20% dying in nursing homes. That's a very sad statistic, when knowing that with hospice, that's really what we're trying to do, is provide people that independence and ability to die within their own home. So what makes up a good death? If we ask our patients, they want to die suddenly, or die in their sleep, or quietly, and die without pain. In other words, they want a quick, painless, and peaceful. If we ask healthcare professionals, they say pain-free, peaceful, anxiety-free, that the family is going to accept it, that we're honoring cultural considerations, and that the patient was comfortable. They're very similar. If we go to the Institute of Medicine's definition, a good death is one that is free from avoidable distress and suffering for patients, family, and caregivers, in general accord with the patient's and family's wishes, and reasonably consistent with clinical, cultural, and ethical standards. But the art of living well and the art of dying well are actually very similar. If you think of how you want to live in life, you don't want to be in pain, you want to be comfortable, you want to know that your family is there to support you and love you, and that's how people want to have their death as well. That they're comfortable, that they're not in pain, and that they're being supported. So part of the importance then is trying to know when death is coming and understand what to expect, trying to keep control over where death is occurring and how it happens, maintain a sense of dignity and some control over pain relief and other symptoms. Understanding our patients' feelings, understanding what their concerns are all established through discussions with the patients and finding out what's most important to them when we bring them onto service. And those communications continue out throughout the entire process. So it's all a matter of good communication. We establish their goals of care, what are their needs, and then we act as their advocates, providing compassionate care. So a big part of that is prognostication. All of our patients want to know, how long do I have and what's going to happen? So none of us can we say, no one's got stamped on them and expires on date. In fact, I remember telling that with my mother when she was first going on hospice, and she used to ask me frequently, how much more time do you think I have, Frank? I'd say, Mom, I've been all over your body and I've yet to see an expires on date. I said, but there are things that we can go with to try and get a better prediction. And a lot of it is the disease trajectory. Cancer, you have a very rapid decline versus organ failure. You're going to have very large ups and downs, but the ups never go past your baseline. In fact, they always seem to fall slightly below the baseline where you're or the peak of where you were before. So it's a gradual saw step downward. Versus dementia is a more gradual, but not nearly as high ups and downs. And of course, sudden death or decline is a very almost straight off the cliff drop. So it's important to understand the disease trajectories to be able to understand the plan of care and plan for our needs of our patients. Helps us talk with our patients and the families to understand and prepare for what might happen, and trying to attack those psychological, social, physical, and spiritual needs based on each of the trajectories. If you know that your patient is going to be potentially expiring very rapidly, we know we don't have a lot of time to plan those things. And so we're trying to get everything in order as fast as possible. Versus if we have a longer trajectory, we have a little bit more time to be able to work on those things. And I can do that as simple as, the example of my mother again, who had a organ system failure. She had pulmonary fibrosis, idiopathic pulmonary fibrosis. We had a much longer trajectory of her decline. So we had a lot of time in which to plan everything towards even her funeral, which she actually planned, as well as, taking care of where finances were going to go and who was going to get what based on her wishes and my father's wishes. That's far different than someone with cancer who may be going within days of finding it and finally going on to hospice. In fact, one of the most staggering statistics for hospice is that 25% of our hospice patients die within 24 hours of coming onto hospice service, and 48% of them die within 7 days. So if you think that almost half of our population isn't surviving past a week, and a quarter of them don't even survive past the 24-hour mark, it's kind of staggering. Most important thing for hospice that I always try and remind myself is that people are going to forget what I said, people are going to forget what I did, but they're never going to forget how I made them feel. And so when I go into my patients' rooms and their houses, we talk. And that's the biggest thing that I can provide as a hospice nurse, is communicating with my patients and answering their questions and trying to anticipate what questions they might have and talking about those. And every patient's different. You can't go in with a set, this is the talk I'm going to give because this is a new patient. You kind of have to assess the room. What is this my patient needs for this particular event? This is their disease process. How is it affecting them? How is it affecting the family? Is the family tearful? Are they in acceptance in the grieving process? So you kind of weigh all those things, and then you deliver your message and what you want to communicate about hospice based on what their needs are. And here's some references. And now I'll open it up to questions.
And it was really great, Frank. I think you covered a lot of information that I asked you to come on just for the main reason of there's so much that I even misunderstood about hospice early on. And I think that even if you're listening to this, there's a lot of things that I learned from your talk that I was unaware of, especially that statistic of how many people I know a lot of people die in the hospital because that's where I primarily started working, and I was there for a lot of deaths. But most people would want to die at home, and they're not. It seems like we're missing something.
Yes.
At this time, anybody has any questions, feel free to enter those into our comment box. We'd be glad to take those. Panels, do you have any questions for Frank? Feel free to go ahead and ask them while we're waiting for questions to come in.
Lori, do you have any?
Yeah, I have a question. So 20% of them die at home. So the other percentage, are they just patients that are already in the hospital that die, or are they having to go to the hospital acutely for something else?
Well, again, this is all patients, not necessarily just the hospice patients. So 60% of people dying in the hospital.
Okay. Thank you for clarifying. That was a great talk. Thank you.
Thank you. And from a urology perspective, I know I've reached out to my brother on a couple occasions because we deal with a lot of urological issues in hospice. Hospice, you have to kind of have a little expertise in all the different areas because you don't know what your patients are going to come in with. So I remember the first time I came in with a patient who had a filleted penis from long-term catheter usage. And I'm looking at going, I've never seen this in my entire career. I was a critical care nurse initially. We didn't have patients in long enough. And even with hospice, for the most part, you don't have patients with you that long, as I stated statistically. But this was one of our long-term hospice patients. And I called up my brother and said, have you ever heard of this before? This is what I'm seeing. He goes, oh, yeah. So I, and gave me some suggestions of what to do and, moving the Foley catheter and putting it in different securement locations, in a clockwork fashion. So it's not always sitting pulled towards one side will help prevent that in the future. And so, of course, I brought that to our team. And this is something that none of my team had ever heard about as well. So, being able to bring some of the urology talks that you guys give and you guys provide into what we do has really been helpful.
We're glad to help out. I'm sure John's seen enough of those cases too with those filleted penises. And Lori, I'm sure you've seen your number of filleted penises.
Thankfully, urethral erosion is not common in the acute setting. Usually it's in someone who has been debilitated or someone who's had a worn catheter, just never got the care that he really needed. And not necessarily men only, but sometimes, rarely, thank goodness, among women. I remember seeing those cases mostly during residency when patients would travel from far away. They never got the care that they needed necessarily at their home location, so they ignored those problems. And by the time they presented to the urology clinic, they've had horrible urethral erosion, totally preventable. So my question for Frank is, have you had anyone graduate out of hospice not being interred?
I personally have not. Again, I work only 2 days a week, so I don't usually, and I'm not a case manager, so I'm a support care team. But I know we have had occasions of patients who have graduated off of hospice without having died. So yeah, and we've had patients who graduated, come off of hospice, and then later went back on hospice. It's one of, again, the nice things about hospice. You start a new period, a new period for your 60 or 90-day period, your initial periods for hospice. But just because you come off a hospice, all that does is end the period. And when you start back on, it starts a new period. It doesn't change your coverage. It doesn't change your costs. You can have multiple periods. The initial certificate of terminal illness is that you're expected to have died within 6 months. We have patients who don't die in 6 months. You may have an Alzheimer's patient who's on hospice for years. And every time we finish a period, the hospice physician has to come back in and reassess, does this patient still meet criteria for hospice? Is the diagnosis still something where we have a life expectancy of 6 months or not? And just because they didn't die in 6 months doesn't mean that the life expectancy still isn't 6 months or less. It just means that they're beating the odds.
We do have some questions coming in from the audience. Susie Swain asks, can patients can continue cancer treatments on hospice? So that you'd mentioned that. Is that right?
Yes.
And Jean Dern, thank you, Frank. What is your opinion about the percentage of people who die within 24 hours of admit to hospice? Could one say then that hospice care is offered too late in the patient's healthcare journey? Are families afraid of accepting hospice, meaning families do not understand what hospice care offers? Great presentation. Thank you for the care you provide. So you got some comments on any of that? The too late part?
I think a lot of the reason we have patients dying within 24 hours, besides just the seriousness of their illness, is the lack of understanding on hospice. You know, that percentage may drop if people understood more of what hospice was to a lower number. It's still going to be a potentially high number. It could drop to like 18. You know, I'm speculating on that number just because of seriousness of illnesses. That's a factor you have to consider. But if people understood more about what hospice is and what hospice offers, I think they would probably go on it sooner. Perfect example is my niece. When she was on hospice, I had a lot of discussions with my sister. Sorry, with my sister about what hospice is and what hospice offers, and so I was able to help eventually guide her in. But even with her, I don't think her hospice journey was more than a week.
So do you think it's more of a lack of education on the clinical part, or is it denial by the family?
People think hospice is, well, I'm dying now. And they're not. The sad thing about death is people think it's optional. We use terms like acid. We don't want to talk about death. And death is not optional. We're all going to go there. It's something that we need to talk about more. And I think if people were less afraid of that, they might be more willing to go on hospice sooner and not try and fight off until there's really nothing left.
I think a lot of people misunderstand too that hospice can provide a lot of care items that you would otherwise, as a caregiver, have to try to figure out how to get, such as a hospital bed.
Yes.
I don't think it's like Hoyer lifts to get in and out of a bed. The oxygen, if you go on oxygen therapy, all these things that, I think for most people are overwhelming. You guys come in and just say, hey, don't worry, I'm taking care of it all.
Yep. That's exactly correct. And
if I could share a story with you guys.
Sure.
This is unlike the typical hospice story. This was back in 2021. Keep in mind that the pandemic was still in full swing. I heard that my dad in California had fallen and he was not doing well. So I flew back to visit him. And I thought, well, I'm going to bring some supplies with me if I could. I want to be able to see what's going on. When I arrived, he had lost a lot of weight and he had lost appetite. He was extremely weak. He was tachypnic the whole time I was there. He was coughing a lot. He looked horrible. On top of that, he's 90 years old. Okay. If I thought, okay, well, if I take him to the hospital, I'll probably never see him again because of all the restrictions regarding the pandemic at that time. And he'll probably not be able to interact with family with such a dire situation. And at that time, I had equipment in the office, finger pulse oximeter. I had several of those. But unfortunately, my patients during that pandemic period leading up to 2021, my patients stole my pulse oximeters. Before I went to California, I ordered one of those from Amazon to be shipped to my parents wherever they were staying. I had them shipped there. The afternoon I was leaving, it arrived. I opened it up with my sister who was helping care for my dad. And I just figured, I'll just put it on his finger. and see what he's doing. And I don't know if you can see that on the screen.
Mm-hmm.
70%. He was satting 70%. So panic set in. I thought, this is not compatible with life. I didn't know what to do. Sending him to the hospital would be most likely a death sentence. He'd be done. He would die alone, and we would not, as a family, would not be able to see him and care for him. I called the primary care doctor I knew, and he said, well, here are the options: ambulance, hospital, etc. Those scenarios I knew. But he suggested calling hospice. I have never personally called hospice. I called hospice, a local hospice, with my sister, and I ended up writing some of the letters, generating that, faxing it over to hospice. Within 3 hours, this is how incredible this. This was on a Sunday. Within 3 hours, they had oxygen, they had walker, they had a hospital bed, they set up services, they had an oxygen concentrator at where my dad was. It was incredible. His oxygen saturation went up, and over the course of several weeks, he slowly recovered. He'll turn 93 this year. So it was an incredible service. The counselor, the liaison who came out, talked to us about end of life planning, making sure the end of life affairs are in order. And she told us that to pick a funeral home sooner than later, because of what was happening during the pandemic, there's a backlog to get into a funeral home, to have those funeral services. Yeah, insights that you never think of. But my dad survived. I just want to share that. Hospice is not, although mostly it's for end of life, but we thought he was done. It turned out to be pneumonia. It wasn't COVID.
Great story.
Yes, fantastic story. You know, one of the things, again, statistics. Statistically, patients with the same disease process tend to live longer when they go on hospice. And I think the reason that is because they're having their symptoms taken care of and they're being more comfortable versus, the fight that they're in. It's amazing to me how many patients live with pain. That's not necessary. We give, a lot of narcotics, but our goal, again, is not that we're trying to cure this person. We're trying to keep them comfortable and out of pain. And so, we increase our narcotics. And if it gets to the point where we can no longer control it in the home environment, that's when we go to a GIP where we'll have someone on a morphine drip and controlling their pain on IV drips, because it's more important that the person's comfortable to me in those final stages. I remember having to have talks again with my mother when she was on her death's door, and she didn't want to take morphine because she was afraid she was going to get addicted. And I'm like,
I remember that.
Really? I finally convinced her to keep the syringe taped to the side of her headboard. I said, that way, if you're short of breath, you can give yourself the squirt and then go back to sleep. I said, you're not having to get up and try and walk when you're already short of breath. Try and find your morphine, draw up the syringe, and then give it, because my father wouldn't have been able to do it at all. And my niece, who was a caregiver, she was in the room next door, but I didn't want to rely on her having to wake up. So I tried to make sure that we had everything set. And this was before I was a hospice nurse. So I think I've always had it in my brain to be a hospice nurse.
Yeah, I think it's really great the things that it's able to do. And I was talking to you about this next door neighbor because he has the same exact disease that our mom died of, and his biggest fear was that he was going to be bankrupt because of hospice, and what was he going to do towards the end? It was this kind of the fear of the end of life, and he knew that my mom went through it, so he's kind of asking me, so what should I expect? And I said, number one, get on hospice. I said, don't wait till it's like the bitter end. I said, you'll know. I said, when you're really having trouble and that oxygen that machine is putting out isn't enough, get on hospice. Let them make those, help you through those decisions, provide it. And I think the story that John told is even more obvious that, how fast they can get these things going, much faster than any of us could. You guys know where to call and where to order and all this other stuff. It really was a fantastic. I mean, for him, he was like, so really, that doesn't sound so bad. I'm like, no, it shouldn't have to be bad. And I told him our mom died very peacefully. And I said, it was a very peaceful death. And he says, well, I guess I can't ask for much more than that. He said, I've had a good life. Isn't that what we all want?
I have a question for the panel. Do you think someone on hospice has to be a do not resuscitate?
I would say no.
No.
Well, now that you asked that question, I would say no. I would have had to really think about it before.
That's correct. That's unfortunately, even in our hospitals, when we have patients on GIP, they think that just because our patients are hospice patients, they're automatically DNRs. That is not the case. We can have patients who are full codes and still be on hospice.
That's interesting.
So Gene Dern asks, are families able to self-refer to hospice? Would not typically an MD need to order hospice?
We have to have a terminal diagnosis from a medical doctor, usually the attending physician and a hospice attending as well. So you can't just put yourself on hospice without having the terminal diagnosis, because otherwise it's not going to be covered.
Now, would I be able to call hospice and say, hey, I think my family member would qualify? Would you guys be able to evaluate them?
Yes, you can call, but ultimately, again, the diagnosis, terminal diagnosis has to come from an attending physician.
So typically it's the primary care doctor or the surgeon or whoever's involved in there.
Right. Or like even with our mother's case, you switch over to your attending becomes the hospice attending. So that can be your attending physician.
Gotcha. Well, these are really great questions. Anybody has any more questions? This is your last chance. We're going to be wrapping it up. This is the 4th of July weekend, and I know everybody wants to get out there and start enjoying that 4th of July. All right.
Yeah, I just want to reiterate that what Frank said earlier, that it is covered by Medicare and the coverage is pretty darn good. If you want 24-hour home care, that is on your own, but the basic hospice care is covered by Medicare.
That 5-day respite, yeah. So if somebody was like had to go on a business trip or something, would that be a qualification?
Yes.
I'm the primary caregiver, but I got to go away for a weekend or something.
Yes.
So that would count. Wow.
So what would happen is the family would contact the hospice team. Our social worker will get involved looking for a facility that's within our network, and then we would organize the transport via ambulance from the patient's home to the respite stay. They would have their 5-day respite stay. The very first day they get to the facility, a nurse comes and does a tuck-in visit, making sure that the patient has all their medications, that the facility is aware of what our plan of care is. And then all of the routine visits that would normally be scheduled at the patient's house are now switched over to the respite stay. And then when the patient goes back, that very first day they go back to their house. As soon as they get back, we have a nurse going out to again do a tuck-in visit, make sure that the family is aware of the plan of care. Was there a change in the plan of care? So that everyone is always up to date to what's going on.
As part of taking care of the patient, when the patient comes into your office and is accompanied by a caretaker, once in a while, you may want to ask how that caretaker is doing. Being in this field for a while now, I am acutely aware of the burnout with the caretakers. So if the caretaker is unwell, it becomes sick, then your patient now suffers. So I always make it a point to ask the caretakers, how are you doing? That's really important.
Yeah, good point. Well, great. I'm going to wrap it up here. Let's see here with a reminder. Next week, we're going to be we're joined by a couple SUNA nurses, Todd Thompson, who spoke earlier for us, and Suzanne Qualich, who were part of the team that worked in the SUNA white paper on the management of patients after suprapubic catheter insertion. So we're looking forward to that talk next week. And be sure to save the date. July 29th is our 1-year anniversary show. It's going to be our 52nd episode. We're going to have raffle off a couple of shirts, and Suna was nice enough to offer a free 1-year membership to be raffled off. Glenn Sully from Suna, the president of Suna, is going to be joining us to talk about what the benefits of joining Suna are. And there'll also be an announcement of something coming new to Euronurse, so you don't want to miss that either. Remember, to be part of those raffles, you will have to be part of the live audience. So for the rest of you, this is our 4th of July weekend coming up. Have a safe and fun holiday, and we'll see you all next week.
Bye, everyone.
Thanks, everybody. Have a good weekend.
Thank you.